Before starting the case, let's talk about the splenic vessels, which run along the posterior and superior surface of the pancreas. Splenic artery is a branch of the celiac trunk. As you know, the celiac trunk gives three main branches. The first one is the splenic artery, then the short gastric, then the common hepatic. The common hepatic artery gives the proper hepatic and the gastroduodenal artery. The splenic vein, together with the superior mesenteric vein, will form the main portal vein. Let's start the case. 42-year-old male with acute epigastric pain and vomiting with previous episodes of abdominal pain. This is very important. The patient has a history of previous episodes of abdominal pain and now has developed acute epigastric pain. CT scan of the abdomen showing. Can you see the pancreas here? This is the head of the pancreas. And when you go up the body and the tail of the pancreas, okay? I can see diffuse enlargement, especially of the pancreatic body and tail, okay? With indistinct margins. I can't distinguish the pancreatic margin from the surrounding fat. Why? Because the surrounding fat show fat stranding. So there is diffuse enlargement of the pancreatic parts or the pancreatic parenchyma with indistinct margins and adjacent fat is stranding. If you look carefully, you will see that the pancreatic tail, the last part of the pancreas, the pancreatic tail contains several cystic lesions. With one of these cystic lesions, or the largest one of these cystic lesions, this is the largest cystic lesion. This is the largest cystic lesion. The largest cystic lesion contains a well-defined oval-shaped high attenuation of similar attenuation to the adjacent vascularity. This high attenuation lesion is seen anterior to this blood vessel, is seen anterior to the splenic artery and also in contact with this splenic artery. So this high attenuation lesion is seen anteriorly and in contact with the splenic artery. How did you know that this is the splenic artery? If you go with the splenic artery, okay, you see that the splenic artery originates from the same origin of the common hepatic artery. This is the common hepatic artery. And this is the splenic artery. Both of these arteries originate from the celiac trunk. Again, celiac trunk gives the common hepatic artery. gives the common hepatic artery. This is the common hepatic artery. And this is the splenic artery. Okay. What about the splenic vein? Can you see this? This is the splenic vein. The splenic vein is seen here together with the superior mesenteric vein. The splenic vein and the superior mesenteric vein is joining here to form the portal vein, the main portal vein. So again, the main portal vein is formed by the superior mesenteric vein and the splenic vein. The splenic vein here is attenuated. The splenic vein here is attenuated, and this is associated with secondary abdominal varices, upper abdominal varices. Can you see the varices? All of these are varices. Maybe splenic vein varices, okay? Because the splenic vein here is attenuated and maybe obstructed. The splenic vein here is attenuated. The splenic vein here is attenuated. The interpretation: this patient has diffuse enlargement of the pancreatic body and tail with indistinct margins. You can't see the pancreatic margins clearly from the adjacent structures, okay, or from the surrounding fat, okay, due to the adjacent fat stranding. This is associated with adjacent fat stranding and haziness, okay. The enlarged pancreatic tail contains multiple cystic lesions, which are the pseudocyst formation. So all these findings are consistent with pancreatitis. Okay, all these findings I mentioned are consistent with pancreatitis, enlarged pancreas, indistinct margins, adjacent fat stranding, pseudocyst formation. All of these are consistent with pancreatitis, together with the history of acute abdominal pain with previous episodes of abdominal pain. The most likely diagnosis is acute on top of chronic pancreatitis. Acute on top of chronic pancreatitis with two important vascular complications. The high attenuation lesion here is a splenic artery pseudoaneurysm formation, and the attenuated splenic vein here, due to splenic vein thrombosis. Splenic vein thrombosis or splenic vein compression and obstruction, and the splenic artery pseudoaneurysm formation are two common vascular complications of pancreatitis: splenic artery pseudoaneurysm formation and the splenic vein thrombosis or occlusion. As the inflammatory process of pancreatitis can cause weakness and erosion of the adjacent blood vessel, this may lead to the pseudoaneurysm formation and the occlusion and thrombosis of the splenic vein. So the diagnosis here is splenic artery pseudoaneurysm. The management here of the splenic artery pseudoaneurysm, this pseudoaneurysm could be treated by open surgery. So this patient may need urgent surgical referral. The pseudoaneurysm can also be treated by endovascular approach with transcatheter embolization. So this patient may also need urgent interventional radiology or vascular radiology referral, okay? As this pseudoaneurysm has high risk of rupture, so it needs to be treated either by open surgery or by transcatheter embolization. That's it.